All right. Once again, thank you for joining our Global Critical Care Fellows Seminar Series for 2024 between the Hollywood Hospital, Johns Hopkins Center for Global Emergency Care, and the St. Paul's Hospital Millennium Health Center. This is a running series for now. It's now in its fourth month, and which will be running in perpetuity. For every week with lectures for our fellows in critical care in Ethiopia and Ghana. We will be welcoming other fellows from a few other countries in the next few lectures, including Nepal. Um, I want to take the opportunity to introduce our presenter for today. She's in the person of Dr. Youn-Hoa Jung. Dr. Jung is a cardiac anesthesiologist and critical care physician from Johns Hopkins Hospital. After completing her intern year at George Washington University Hospital, she completed her residency and fellowship in critical care and cardiac anesthesiology at Johns Hopkins Hospital. She stayed on as faculty, first as a T32 research grant recipient, then as an assistant professor in cardiac anesthesia and intensive care medicine. Her areas of ongoing research and interest are in the study and application of computer vision and robotics in the medical fields. We are very honored to have Dr. Youn join us and present on the fixed principle of cardiac output monitoring in the intensive care units. Dr. Jung, please, your audience. Thank you.
Thank you so much. I really appreciate the opportunity to give this lecture. So I'm hoping it'll be interactive. Please feel free to interrupt me, and I really hope that you guys get something from this. I understand that most of the audience is composed of critical care fellows, and I understand some faculty may be joining us as well. Is that correct?
That's correct, you know.
Okay, great. And so I was tasked with this topic of fixed principle, or the Fick principle of cardiac output monitoring in the ICU. And we were talking about this a little bit before starting the actual lecture. I was just curious about you guys' experience in the ICU and whether you use Fick principle for cardiac output monitoring routinely, not routinely. Just kind of opening it up to you guys to make sure that I'm not going over something that you guys do all the time.
So kindly, the audience, you can unmute to just share the experience of what's, or raise your hand and I'll just call you to share experience of what the application of fixed principle in your current place of work. So any of the fellows who currently use fixed principle in the ICU for their cardiac output monitoring, kindly either raise your hand or feel free to unmute yourself.
Hello. Maybe I'm from Ethiopia, St. Paul's Hospital, and we usually don't use fixed principle for cardiac output monitoring.
Thank you, Enoch. What about those from Ghana, Kolebu Hospital, Greater Accra Regional Hospital, UGMC? and then Confanoche. I can see all of you represented here. Can we have some response? Okay, Doc, I think you can carry on.
Okay, great.
Yeah.
So I think the experience in our ICU, even within our hospital, is very variable. So I attend in both the surgical ICU units, which encompasses patients who have illnesses such as cancer, oncology, transplants, trauma, etc., to also attending in the cardiovascular surgical intensive unit, which is much more specific to patients who have undergone cardiac surgery. I would say overall, my experience has been both as a fellow and attending in these units that most of the surgical and the surgical oncology ICU units rarely use Fick principle for cardiac output monitoring in the ICU, but the advanced practice practitioners and some of the attendings in the CV-SICU are more likely to use it. I think partially because of the pathophysiology and the patients, and partially because of the training, and also because not a lot of patients outside of the CV-SICU routinely get PA catheters, which is a component of using Fick principle for cardiac output monitoring. So I think similarly for us that the use of the Fick principle for cardiac output monitoring is very variable, but I do think that understanding the principle behind it and kind of the brief history and understanding what someone is talking about when they mention this is important, and as well as understanding the caveats. So that's what this lecture will go over today. So let's see, no conflict of interest to disclose on my part. And the learning objectives, as I mentioned, will be to understand Fick's principle, discuss how to apply it in determining cardiac output in the ICU, understanding the limitations, and then perhaps also exploring the alternatives in cardiac output monitoring. So the brief history behind it is that this principle is named after Adolf Eugene Fick, who was a German physiologist. And in 1870, he devised the Fick principle, and he actually presented it very shortly in the proceedings of a conference. The principle itself basically says that if you suppose a fluid has a flow of F and contains a concentration of a marker, as it flows through a compartment that adds the marker in the fluid at a rate m, at the exit of the compartment, the fluid has a concentration C2 of that substance. And basically the difference in concentration and the rate in adding that marker in the fluid will give you a relationship for the flow of the fluid through that compartment. If we treat the oxygen as the substance and the compartment as actually the body, then we can use the oxygen consumption, MvO2, sometimes you'll see it as V.O2, in cc's of oxygen per minute per 100 grams of tissue, as well as the cardiac output, which we typically express as cc's of blood per minute per 100 grams of tissue, and then the concentration of oxygen in the blood as CaO2 and CvO2 for both the arterial and the venous contents. If we take that former equation and say the flow is cardiac output and we multiply it by the arteriovenous difference, then we can get the rate of consumption of oxygen in the body. And because we're actually calculating for cardiac output, we can do some simple math and say the cardiac output is then equal to the oxygen consumption divided by the arteriovenous concentration difference in the blood. Any questions so far? Okay, so the oxygen consumption is the inspired expired oxygen difference. And in lab situations, basically it's you have a set amount of oxygen that you're delivering to the patient, and then you're measuring the actual expired oxygen difference. And you may have seen this on like exercise treadmills or with Douglas bags, which is very, very large bags, but it's very, in order to do this using the direct measurement method, you require lots of specific measurements for actually measuring exactly how much oxygen you're giving, and then after what the patient uses, to actually measure the expired oxygen. And the arterial and the venous oxygen concentrations are measured using a radial arterial blood cannula, using the arterial blood gas, and a pulmonary artery catheter using the mixed venous blood gas. And the equation here is the O2 content is equal to the saturation of the blood times hemoglobin times 1.3, and I put star. And this is a very simplified version of the equation, because you'll see anywhere from 1.31 to 1.39 as your concentration, as your constant difference. And it also emits the small amount of contribution to the oxygen content by the dissolved oxygen content, which is 0.003 times the PaO2. And under normal physiologic conditions, it's pretty non-contributory, and therefore I just omitted it from this. But it's going back to physiology from medical school to say you have to calculate the O2 content from the measured concentration using different methods, and also then to measure the expired oxygen difference in order to do the Fick principle method of cardiac output measuring directly. So obviously this is not very practical. The MVO2 to measure this is very cumbersome. And because you're assuming then that this compartment is going through the lung and that the rate of consumption of oxygen in the lung is representative of the rate of consumption of oxygen systemically. But this may not always be true, especially in our patients in the ICU, especially if they have pulmonary ailments, because the pulmonary O2 consumption may actually be non-trivial and therefore may not actually equate to the systemic consumption of oxygen. And not only that, but the CaO2 minus CVO2, the arteriovenous difference, it's actually can be quite inaccurate. For example, in the case of an intracardiac shunt, if you have a right to left shunt, for example, then you have an admixture of venous blood on the left side or the arterial side. And conversely, if you have a left to right shunt, then you can have a raised, the CVO2 can be raised, which is not representative of systemic oxygen consumption again, but actually of intracardiac shunts. And it can also be different based on what your actual disease state might be. Although in essence, part of this is understanding and getting the nuance of when these may be different. So in the ICU, for practicality, people have used estimations for the oxygen consumption, and sometimes also the arterial gas content and the mixed venous content. The most common thing that gets estimated is the oxygen consumption. And usually it's done either using a nomogram based on age, weight, and sex, or using common equations for calculating the oxygen consumption. Arterial gas content is typically readily available in most ICU patients who have radial arterial or any sort of arterial cannulation, and therefore is not usually estimated, but just measured. And then the mixed venous content, not all patients have a PA catheter. So sometimes a central venous sat or a central venous blood gas is used instead. So if we were to say this is under normal conditions, and this is where a lot of these numbers come from, a very common equation, although criticized for potentially being not so accurate, is the Demmer, First, and Hillis paper published an equation where basically the MVO2 was a calculation of 125 times the BSA. And so if we take 1.9 as an average BSA, which is in a 70 kilogram male, which is clearly not the case for most of our patients, we get about 237.5 cc's. And then if we take 14 grams per deciliter, or 140 grams, I guess I should say, for our hemoglobin, and just normal values of 100% SAT and 75% venous SAT, then doing these calculations out with a constant of 1.34, we get an AV difference about 46.9. When we divide this oxygen consumption value by the AV difference, we get 5 liters per minute, which is something I'm sure you guys have seen quoted as a normal cardiac output for under normal physiological conditions. But this is one of the ways that this number has come up. But obviously, this is not really the case for most, if not all, of our ICU patients. So I have included a couple of examples, and these are real patient examples that I've taken care of, where I want to give you a brief history and then also kind of go through the calculations together and hopefully open up to discussion at each point during when we would do these calculations, about what you guys might do. So the first calculation, or the first case, is a 67-year-old male with a history of hyperlipidemia who was post-op day 0 from a 3-vessel CABG. He comes in basically as a fresh admit. On pre-op transthoracic echo, he has an EF of 60%, no significant regional wall motion abnormalities or valvulopathies. And then on the intra-op TEE, on sign-out, you get a report that you have similar findings and that the LVEF is estimated at 55 to 60%, and the RV function is normal pre and post bypass. He arrives to the ICU on 0.03 mics per kilo per minute of epinephrine and nothing else. So on emission labs, his weight is 90 kilograms. His height is 180 centimeters. And so I calculated the BSA for you guys, just 2.12 using the Dubois formula. And his ABG shows a gas of 7.39, 39, 99, calculated bicarb of 21, and a SAT of 97.6 on an FiO2 of 50% because he's still intubated. The venous blood gas, which is actually a central venous and not a mixed venous, is 7.31, 49, 33, and a calculated bicarb of 24 with an SVO2 of 52.8. And his hemoglobin on emission is 12.1. His hemodynamics are stable. And if we go back to this calculation, our oxygen consumption is, by the Denver formula, 125 times the BSA, which is 265. And just so you guys don't have to have calculators and such, I did these calculations, but if you guys don't follow where these numbers are coming from, please interrupt me so I can go over them. The CaO2 is 0.976, which comes from the SaO2 times 1.34, a constant, times 121, which is our hemoglobin. And then in this case, I did include the dissolved oxygen content, which is pretty minimal, but it's 0.003 times the PaO2, 99, and that is 158.5. The central venous SAT is 52.8, so the CVO2 is 0.528 times 1.34 times 121, which is again the hemoglobin, plus the oxygen content, which is 0.003 times 33, and that's 85.7. If we try to calculate the cardiac output based on this, we have 265 from our oxygen consumption estimation divided by the arteriovenous content difference, and we calculate 3.6 liters per minute. And if we divide that number by the BSA, we get a cardiac index of 1.72. So I will open this up to the group to ask, what do you do for this patient now that you've admitted this patient? He's come in overnight. You're admitting this patient and taking care of this patient, and you do this number, you get these hemos, you know that the patient is on 0.03 mics per kilo per minute of epinephrine. So how would you manage this patient? Would you give volume? Would you stop giving volume? Would you diurese? Would you increase the inotropy? Would you wean the inotropy, add on a vasopressor? Would you wean towards extubation? Would you keep intubated or mess with the FiO2? I just presented some ideas, but what are some things that you guys might do, or maybe nothing at all?
Youn-Hoa,
Yes.
Can we go back to the slide before, just to make sure that everybody is happy with the numbers that you have here? With respect to your ABG and VBG, the representation. So the 7.39 and 7.31 are for your pH. The 39 and 49 are for your PCO2. Is that my understanding?
Yes.
99 and 33 are your PO2,
Yes.
arterial and venous PO2. And then 21 and 24
Are they calculated by carb?
the bicarb. Okay. All right. So I hope everybody does, because the representation may be different
Yes,
with respect
absolutely.
to how we write them out. And then, of course, these are your saturations. Okay. So my other clarification is that the venous sample was taken central venous, not means venous.
Yes, exactly.
Which is possible for every, basically both our fellows here and then in Ethiopia, even without a pulmonary artery catheter in. Okay. So guys, so these are basically the calculation of the cardiac output based on this, without Swangan in, more or less. So anybody else need any clarification here with calculation of the oxygen consumption, oxygen content, arterial and venous? Basically, these are already known equations where this been imputed in, and the calculation of the cardiac output using a division of the oxygen consumption by the arterial venous difference in oxygen content. Okay, so somebody is asking, Kakiden is asking, why have we rounded off the hemoglobin? The hemoglobin was 12.1 gram per deciliter.
Yes. So for units, it's 121 grams per
Yeah.
It's not rounded. It's just a decimal point calculation
Yes.
based
So it's
on
not rounded. It is
Yeah.
now grams per liter.
Yes, because we want to get the cardiac output by liters per minute.
Liter. Yes.
Mhm.
So that is the 121. So the 12.1 is what you have here now as 121, but not grams per deciliter, now grams per liter.
Yes, thank you for that clarification.
Please, any other question on this? Then we can move to the questions. And any comment? So, you can go ahead. You can move to the next page, I think.
Oh, sure.
Everybody should be. So please, contributions as to what you would do for this patient at this point.
Hello, this is Esther.
Yeah, Esther, thank you. Go ahead.
Yeah, okay, so looking at the ABGs, it looks to me that the gases are roughly okay. So I wouldn't change anything about the FiO2. I wouldn't decrease it just yet, even though the PO2 is, it's normal. Maybe we don't need it to be 99, but it's okay. But looking at the main thing that sticks out to me is that the cardiac index is lower than it should be. And so the blood pressure, the heart rate, they are okay, but it just means that the patient may need some inotropic supports in addition to what we are doing. And possibly if we start the inotropes, we may be able to come down on the vasopressor even, because it will increase the cardiac output and the blood pressure will maintain. That's my thoughts.
So Esther, where would you want the cardiac index to be? What would we be happy with?
Yeah, so I think above 2.5 or
Okay, Youn-Hoa, what do you?
Yeah, so just to cut off on the CI, typically we'll say greater than 2.2 as our goal for our cardiac index. And I think that well, Esther, first of all, thank you for sharing and thank you for volunteering. I know it's always difficult on Zoom. So I did kind of lead you down this way, right? So we have an epinephrine of 0.03 mics per kilo per minute. He's a fresh post-op. If we drop the FiO2, maybe we'll even decrease the oxygen content even more on the blood. And based on these calculations themselves, our cardiac output is only 3.6 liters per minute, and a cardiac index of 1.72 is not enough. But if you go back to the original presentation of the patient, it was a pretty routine cardiac surgery, a routine bypass surgery, and his function was normal before and after bypass, and the RV function was also normal, which is all pretty reassuring. And when they arrived, they were on a pretty modest dose of epinephrine as well. And like you said, the hemodynamics are pretty acceptable and reasonable. And so if we were to do all of this based on, sorry, I got a little distracted. I don't know if there was a question for Dr. Jagema. Okay. So if we, sorry, go ahead, Chris.
No, there's no question.
Okay. I guess I just see markings, and so I just wanted to make sure. So the cardiac output and the index based on this is very worrisome. But everything else, let's say you didn't know how to do this and you didn't do the calculation, you didn't get a venous gas or an arterial gas, and you saw this patient and you laid eyes on this patient, and they're warm and well perfused, and the hemodynamics look pretty reasonable. Would you do anything different for this patient? How do we progress this patient?
So Esther, let me drag you back in again until a few other people are able to contribute. So what Youn-Hoa is asking is, let's say you did not calculate the cardiac output and cardiac index of this patient. Surgery went well. Patient was uneventful at the beginning on your transesophageal, transthoracic, and then coming out. You have a heart rate of 80. You have a blood pressure of 110 on 64. And this patient is making this saturation and this PO2. Would you chase it?
I think the saturation looks okay to me. And the PO2, I mean, it's within normal range. If the patient was doing really well, I would be thinking, okay, maybe I could reduce the FiO2 and see how they manage with it. But the thing that worries me is that the patient is on presses. I'm just wondering, like, aside all of these, I would be interested to know if their volume, like, they are fluid responsive or not. If that's not part of the problem I'm dealing with, then that's why they need to be on presses. But I mean, without all these calculations, with this blood pressure and this heart rate, the patient looks stable. The only thing is that there's the central venous, I mean, the saturation from the central line is quite low. It means that the patient is using up quite a lot of
oxygen.
Yes, so I would wonder why that is the case, but I don't know from this.
Yeah, Esther, I think you bring up really good points. And so
Yeah.
I agree with you on this. So this is actually a really hard case to say this. There is no black and white here, I would say, in terms of how to manage this patient. And obviously, part of this is going to be my biases and how my style of managing a patient and my experience. But you brought up really good points here in terms of like the FiO2, in terms of the PaO2, that in and of itself is very reassuring. We don't really need the PaO to be 99%. And so I agree with you that weaning the FiO2 is probably pretty reasonable. And you brought up this question is like, does the patient is on pressors? And so typically very frequently after cardiac surgery, and this is, I think institutional, part of it is institutional preferences about what type of inotropes and vasopressors that people want to use. And seeing someone on a pretty modest dose of epinephrine after bypass is relatively common, even in the setting of even in the setting of preserved LV ejection fraction and preserved RV ejection fraction and function at our institution. And so, one of the things that you bring up is, well, the patient is on pressors or the patient is on inotropes. And the counter question I would have for you is, well, does the patient need this inotrope? Is this something that we can try weaning? Then you very astutely pointed, well, the SVO2 is quite low. It's 52.8, which is lower than what we would like to see, obviously, for this. And that's also what's contributing to a lower CI in this case. And so there's no correct answer per se, but I do think that there might be a little bit of hesitation in seeing in weaning the inotrope, even though from a hemodynamic standpoint, I think it's very reasonable. Because that SVO2 is low, you might have some reservations. Am I summarizing that correctly for you, Esther? And anyone else?
Yes, please. But I was also then thinking that then with the calculation showing the cardiac index being low, that's why I thought that giving an inotrope would help the patient. That's what I thought.
Yeah, so you have a couple of options here. You can say, well, I'm concerned that my cardiac output based on Fick is 52, which is lower than I would like to see it, and therefore it contributes to a CI of 1.7, which is lower again than I would like to see it. So one option would be to increase the inotrope. An alternative option would be to say, okay, well, this patient is doing well hemodynamically. We can maintain the inotrope and see how they do. Or alternatively, we can say, well, the patient looks well otherwise, and this is one number and one calculation. We can wean the inotrope and see what we can do, right? So you have three options. In this case, because this is just what happened and not necessarily the right answer, what happened was the patient was hemodynamically stable and given the echo findings and that it was a pretty routine bypass run and the surgery went well. The patient was actually weaned to extubation overnight and was extubated within 6 hours, and the patient's repeat gases and the epinephrine was actually weaned off. And these were the numbers that were obtained after the patient was weaned off of epinephrine and extubated. And this is kind of providing a feedback, right, for what your decisions are what the decisions you made, what the feedback is. And so for him, the same weight, height, BSA, ABG was pH of 7.4, PaCO2 of 35, PaO2 of 81 on 2 liters of nasal cannula, and a calculated bicarb of 21. The SaO2 was 96.1, and the venous blood gas was a pH of 7.36, CO2 44, O2 33, calculated bicarb of 25 on the VBG with the SVO2 of 51. And the repeat hemoglobin drawn around the same time was 12.6. The hemos were about the same, and this time the patient was off epinephrine. And if we were to do this calculation again, the oxygen consumption again is 125 times 2.12, which is the BSA, and we get 265. The CaO2 is now 0.961 from a SaO2 of 96.1 times 1.34 times 126 from our hemoglobin converted to grams per liter, plus 0.003 times 81, which is our PaO2, is 162.5. Our central venous is done the same way. Our SAT is 51, so 0.51 times 1.34 times 126, plus our oxygen content in the venous side, and therefore we get 86.2. And when I calculate that, the 265 divided by the difference in the arterial content minus the venous content, I get a cardiac output of 3.5, which is from 3.6 previously, and a CI of 1.6 from 1.7. So now that you have these numbers, and now you know that the patient was extubated and the epi was weaned off, what would you do now?
Any comment from anybody? So just a few comments. This obviously, both the cardiac output and cardiac index are relatively unchanged from the previous one on admission from theater, and on at which point the patient was on 50% oxygen and on some presses. Which basically means weaning off oxygen, basically down all the way to about 24% oxygen and 28% oxygen, and weaning off the presses has not had any significant detrimental effects. Hemodynamically, blood pressure 105 on 58 with a heart rate of 70. It is true that oxygen consumption is still quite significant. The arteriovenous difference in oxygen content is still quite significant. But then bearing in mind that this is a patient who has had a cardiac surgery, wouldn't I be bending towards saying that this looks reasonably acceptable? This is not measuring cardiac output and cardiac index in a patient who is totally normal. Thank you.
Yeah, I agree. And so I think there's still a couple of concerning things, right? The SVO2 is still quite low, and the CI is 1.6 versus 1.7. And so even despite these numbers, the patient is hemodynamically stable and off of these inotropes and has not had a detrimental effect from weaning the inotropes. Alternatively, it could have been done in a different manner. Let's say we could have increased the inotropy and see what the calculated what the measured SVO2 and the calculated output shows. And it may or may not have shown a difference. But what I'm suggesting here, and I hope that message is clear, is that it's not very clear cut, and I wouldn't hang my hat on a management strategy based on just one number, because if I told you that the patient's CI was 1.7, then I would say definitely we need to do more inotropy. We need to support this patient more, et cetera. But given that this patient clinically is warm, well perfused, and with other clinical indications that the patient had a preserved EF going in and coming out of the cardiac surgery, underwent cardiac surgery, is now revascularized and is a fresh post-op, that despite some of these numbers, that this patient, in proof of weaning this inotropy and decreasing the oxygen content delivered by extubating this patient, has remained stable on these, and the numbers look stable, which is, I think, more reassuring. Any questions about this example?
Excuse me?
Yes, of course.
Yes,
Yeah.
please.
In both patients, the cardiac index seems to be a bit low, but we seem to be tolerating it. And when exactly do we decide that, okay, there's a problem with the cardiac index, we can't tolerate this number, and we intervene?
Yeah. So I think from this example, it's that one number, or it's one number derived from another number, right? So the SVO2 is low and the CI is also low. Everything else about this patient, though, seems reassuring, right? The patient is warm, well perfused. The patient is on a very modest dose of pressors, and despite weaning those inotropes, despite weaning the epinephrine, the numbers look about the same. And also the patient's hemodynamics are pretty reassuring, right? So from a clinical standpoint, like, sure, we have this number, we have this understanding of monitoring the cardiac output based on this, but when everything else points to this patient being relatively hemodynamically stable and doing well and progressing, the way that we progress this patient is to see if we can wean those inotropes and to wean to extubation, despite a number suggesting that this patient is in like cardiogenic shock.
And sorry, in relation to this, does it also mean that, like, because the cardiac output is low, the cardiac index is low, but the patient has stable vitals, do we do anything else? Like, do we limit movement? Do we do certain restrictions or something? I'm just trying to understand what the significance of one value being low would mean to a clinical practice, as opposed to ignoring it completely.
That's exactly the point, right? Is that this one value being low should not affect your clinical judgment being at the bedside and looking at this patient, because we did do this calculation and it's just one value that suggests that your cardiac index is 1.6, but there's a lot of caveats here, right? We use the central venous instead of a mixed
Yeah.
venous, when in fact the direct Fick method and the gold standard should actually use a PA catheter. And then also our oxygen consumption, which is a large part of this, is based on a formula or a nomogram, which is problematic. And so although it's a good trend, and it can be used, and I want you to understand how this equation came about and why it's used, it's not always congruent with everything else in terms of your clinical exam. And when it's not congruent with your clinical exam, I'm asking that you critically examine this value and ask, is this value an outlier in the rest of your clinical exam and your clinical determination for this patient's progress forward? Or is it consistent with what you imagine? And in a patient who has a preserved EF, who did well in surgery, who's hemodynamically stable, who is warm and well perfused, and whose numbers really didn't change despite weaning from 0.03 to 0 of epinephrine, my suggestion is that these numbers are probably an outlier to your clinical examination rather than congruent to your clinical examination.
Thank you.
Of course. One thing that does come from this is that sometimes people will use this to say, okay, well, here's the trend. And although that SVO2 does not look great, everything else looks unremarkable or pretty good. And that because the SVO2 didn't drop significantly, or that the CI didn't drop significantly, despite weaning inotropes and vasopressors and extubating, that there probably wasn't a detrimental effect to doing the before said maneuvers, right? Despite extubation, despite weaning inotropes, the patient's calculations and hemodynamics remain unchanged. And therefore, you can sometimes feel reassured that doing these things did not hurt the patient. So that's another way that some people may use these numbers. I have another example. Sorry, go ahead.
Yeah, so the other thing I was going to contribute in on that is, again, this, aside the fact that this patient hemodynamically looks stable, although the numbers are a little bit lower than you would want, this example is not super representative of other non-cardiac patients. So let's also bear in mind that this is a patient who just gone for a cabbage. So although the ejection fraction is preserved, and then the echo values looks reasonable, this patient obviously has a cardiac problem, and therefore these numbers should be taken in context of who is this patient, as against if you were measuring this cardiac output in a patient who is non-cardiac surgery or non-surgical patient. Let's say you had these numbers in a patient who has sepsis and whose blood pressure is not holding. It would be more reasonable to say, I am not too happy with this. The range for cardiac output and cardiac index is a range, and then can be, as you said, needs to be juxtaposed on the clinical of the patient. And that is why a lot of ICUs, as was evident, are not routinely doing them to manage the patient, although probably they should be doing more of it because, of course, if you have a patient on inotropes or vasopressors, where then that's basically confuse totally the numbers you're getting, then that may be more helpful. Thank you.
Yes, I think that those are all very, very good points. I have one more example if we have time. This is a non-surgical patient who presented to the unit. She was a 53-year-old female with a past medical history of non-ischemic cardiomyopathy. EF was 15% on last transthoracic echo about 2 months prior to admission, and presents as a transfer from outside hospital. Presented in respiratory distress and tested positive for enterovirus, was intubated after unsuccessful attempt at BiPAP, and then went into cardiac arrest, achieved ROSC, and was being transferred over to the unit. She presents to the unit on 5 mics per kilo per minute of dobutamine and 0.3 mics per kilo per minute of norepinephrine. And on this degree of vasopressor and inotrope, her heart rate is in the 90s to 100s. Her MAPs are 70 to 75. And on initial presentation, actually, she's satting about 75%. Her weight is 80 kilos, her height is 155, and her BSA is 1.86, calculated out. And on her first gas, her ABG is 7.12, her PaCO2 is 74, her PaO2 is 57, calculated by carb of 23, and her SaO2 is 75.1 on 100% FiO2 by vent. Her venous blood gas shows a pH of 7.13, and the central venous is 76.7, and the hemoglobin is 15. What do you guys think about these numbers?
Please, any comments? These numbers looks quite interesting. So any comments?
It seems like the patient's oxygen uptake is not as it should be, or she has a severe type of acidosis with oxygen concentration of the arterial, which is lower 57, and the venous is also similar.
Yes, absolutely. I mean, this patient is clearly very, very sick, right? The ABG and the VBG practically look the same. And without doing any sort of calculations at all, you can already, it suggests basically that there's no extraction whatsoever. And that not only that, but what's being delivered to the arterial side is grossly inadequate. Does that make sense?
Yeah, so that's why I said this looks interesting, because already the denominator for your cardiac output calculation is already going to look very little, even before you start calculating, because there's no oxygen being extracted on the venous side. Even though the amount on the arterial side is low, even on 100% oxygen, it's not being utilized at all.
Exactly. And this is, I know sometimes when you see this, you might think, oh, maybe they both drew it from the venous side, but I do think that this was drawn from the arterial side. And this is not entirely uncommon in patients who just underwent cardiac arrest. And if you can imagine the idea of cardiac arrest and not having cardiac output, et cetera, it's not uncommon to have this degree of derangement. So in this case, we won't do this calculation at this point because you can already tell that there's no oxygen extraction going on and this patient is very, very sick. So this patient actually went to the cath lab and had a PA catheter placed while also being stabilized. And these are the numbers on the PA catheter. The central venous pressure was 23. The PA pressure was a 87/45 with a mean PA pressure of 61, and the wedge was 29. And this was in the setting of being ventilated on volume control with a tidal volume of 300, rate of 30, PEEP of 20, and FiO2 of 100%. So just looking at these numbers, looking at what the patient is on, looking at the ventilator settings, the past medical history coming in for a viral respiratory distress, having issues with like basically being in ARDS, being in shock, being in what type of shock would you say, just based on these numbers?
So obviously, the patient is in cardiogenic. Yeah, go ahead.
I was just saying, any volunteers? Go ahead, Chris.
Yeah, so as I was saying, just looking at the patient's history, the numbers and all this, basically you have the patient in cardiogenic shock.
Yes, absolutely. Elevated right-sided pressures and elevated left-sided pressures. And the concern, of course, too, is that you have an ARDS picture. Now, is it contributed by the left heart or is it contributed by the fact that the patient had enterovirus and is maybe developing additional issues with ARDS? It kind of remains to be teased out at this point. But regardless, this patient is in significant shock. And most concerning is based on this history of non-ischemic cardiomyopathy of 15% coming in for an enterovirus, right? And having these numbers on PA catheter, that this patient is in fulminant cardiogenic shock. So this patient coming back now shows these numbers, a little bit of a better oxygenation. The ABG and VBG are still very concerning. But if we were to calculate this out, right, and say the ABG was 7.22, PaCO2 of 55, PaO2 now of 203, and a SAT of 99 on 90% FiO2 because they were able to wean it down. The VBG was 7.23, 54, 41.6, 22 with the PA cath now it's with a mixed venous of 69.3 and a hemoglobin of 13.7. If we calculate all these numbers out in the same fashion that we did before, our cardiac output is now 4.2 liters by Fick, or a CI of 2.3. What do these numbers suggest that you do?
If I can try, there seems to be better.
Yeah, Helen, go on.
Yeah, there seems to be better oxygen uptake, and her cardiac output is improved. So maybe I'll start winning the FiO2. I'll start with winning her from the FiO2. Yeah.
Yeah, I think that's very reasonable to wean the FiO2, and you're absolutely right. The oxygenation seems to have improved. So, from going in BiPAP and going to shock, into going to cardiac arrest and then being intubated and being on a high PEEP setting, delivering lung protective ventilation strategies and basically trying to open those airways up seemed successful. The PaO2 is now 200 and the FiO2 90% is higher than we need. So I think that by the ARDS protocol and lung protective ventilation, that weaning the FiO2 is a very reasonable next move on this patient. In terms of our cardiac output, what do you think? Previously we said our goal for CI is around 2.2, and this patient's CI calculated by Fick is 2.3. And we do have a mixed venous sat now. And so other than this estimation of our oxygen consumption, this is probably the best that we'll be able to do, aside from doing like a metabolic cart or doing a more direct measurement of MVO2. But our cardiac index is 2.3 now.
It looks normal.
Yeah, it does. I agree. It looks normal. Do you feel okay about this patient? So should we just hold course now that our 5 of dobutamine and our 0.3 of norepinephrine, which is pretty significant dose of vasopressor to maintain current hemos, right? MAP greater than 65 to achieve a CI of 2.3. Do we hold course, hold steady? Do we feel reassured?
I would love to see the vital signs, but it might be a bit backward at this point.
I should have included them, but the vital signs are MAP of 65 to 70 on these settings. On
I think
dobutamine at 5 and norepi at 0.3.
I think I'll hold it until, maybe, yeah, I'll hold still.
Okay.
So I was going to say that again, in this patient, we should remember who the patient is. So not just numbers, because it's not just the numbers we're treating. This lady who is already been known to be very ill with respect to her cardiac function, an EF of 15, 2 months before even this happened. So she obviously had significant cardiac dysfunction, systolic dysfunction. So these numbers we're looking at has a significant contribution to the interventions, both with respect to oxygenation and then vasopressor and intraoperative support in this woman. So we should be mindful. Again, if you look at the SVO2, it is not a whole lot much different from what it was. What has happened is that we are oxygenating her better now. Yes, so there is better oxygen extraction than previously. She's still acidotic, although not as bad as previously. So yes, I will agree on winning down the oxygen with a PO2 of 203. You don't need that. But I would go cautiously with winning down her pressure supports.
Okay.
Yeah, absolutely. And this is also a tricky, difficult patient that requires a lot of multidisciplinary discussion on how to manage afterwards. So I did give you guys two very challenging cases. So this patient is in a lot of trouble. Like you said, this patient's CI looks reasonable, but you know, the SVO2 is not that different from before. And there are some more reassuring numbers like the PaO2, like you said, allowing us to wean her FiO2. And it seems like now we're actually able to oxygenate her and ventilate her more appropriately with the ventilator settings and lung protective ventilation. But again, the CI is just one number. And if you take into consideration, yes, she's hemodynamically stable, but on 0.3 of norepi, right, which is a lot, and dobutamine at 5, which probably is not enough, her CI is being calculated to 2.3. But we know that she came in, she arrested, and even before that, she had an EF of 15% with non-ischemic cardiomyopathy. And if we look at her pulmonary arterial numbers again, her right-sided pressures are extremely elevated. Her PA pressures are near systemic, right? Even if we're saying her mean PA pressure is 61, and if we're barely maintaining maps of 65, 70 even, that her PA pressures and her systemic pressures are almost the same. And her wedge pressure is also 29. So she has very significantly elevated both left and right-sided pressures, suggesting that she's in very significant cardiogenic shock. And really the next step for her at this point is for her to get mechanical circulatory support. So she needs to unload her heart. And for this patient, that's actually what happened is she went on ECMO with Impella, and she's now being worked up for consideration of an LVAD or transplant. So this again is a patient where all of your numbers are very wrong, right? Your CVP is too high, your mean PA pressures are too high, your wedge pressures are too high, your ventilator settings are too high. She arrested, her EF is too low. And even though she's on, her hemodynamics are stable, she's on very high doses of very high doses of inotrope and vasopressor. And if you get these numbers, yes, you can calculate a CI and you get one number, which is a CI of 2.3, and that in and of itself can be reassuring. But if we were to say the CI, if we were to ask ourselves, is the CI an outlier to what my clinical examination and my everything else is, I would say it's likely an outlier rather than it being congruent. There's a message on the chat about decreasing the PEEP. The decreasing the PEEP could potentially help, but in this patient who came in fulminant cardiogenic shock, that it might not be enough, and it is most likely not enough without having additional offloading. So the options I think at this point would be if the patient is someone who could be considered for more mechanical circulatory support, right? Extreme being ECMO in a way to bridge to an LVAD versus a transplant, then that would be a consideration. But if not, then the only other option really would be to go way higher on the inotrope and try to support this patient and offload this patient. Despite, like, regardless of that, that patient should have volume removed, right? So if they're not able to pee, if you're not able to give diuresis, then removing it by ultrafiltration via a dialysis machine, etc. So to relieve the cardiogenic shock would be the only option for this patient, despite what your cardiac output by Fick shows. Does that make sense?
Yep.
Yeah, very difficult cases, and that was on purpose because I wanted to challenge just doing cardiac output by Fick because not all of this falls in line. And really the most important thing, in my opinion, and I think in all of my colleagues' opinions, is that it's really your clinical judgment that you begin to learn how to do this clinical examination, and nothing is better then seeing the patient, examining the patient, and making this determination and understanding what's going on, understanding what the process is, so that when you have numbers that seem like outliers, that you treat them as such. And these are all pieces of evidence for you and all tools for you, but not any one should hold more importance over another than, and especially not over your clinical determination and your clinical examination of the patient. So to summarize, it's a relatively easy way to calculate cardiac output in patients in the ICU, given that most patients will have at least a central line, if not a PA catheter, and an arterial line in the ICU. And direct measurements are almost never made, and therefore we make estimations, and therefore there are variables and inaccuracies that are introduced. And most importantly, that different disease states in the ICU may impact a degree of divergence. We talked about kind of in pneumonia patients where the pulmonary contribution might be a lot higher, for example, even if you were to do a direct measurement. And in fact, in heart failure patients, when they made measurements for the oxygen consumption and compared them using a metabolic cart and compared them to patients who compared them to the the oxygen consumption based on formulas or thermodilution, it was found that the worse your NYHA, New York Heart Association functional status was, that the larger the discrepancy was between these estimations that we use very routinely versus what was measured on a metabolic cart. So there's, depending on what you look like, this degree of divergence in your numbers and your calculations may be quite large. Just because we're running out of time, these are my references and my email in case you guys wanted to keep in touch or if you have any questions.